Good morning, everybody. Now we are going to discuss about the treatment plan of different malocclusions. We have seen in our earlier classes what is a malocclusion is and what are the different types of malocclusions. Now we are going to discuss about the treatment of these common malocclusions. We have seen different etiological agents and how to diagnose these malocclusions. What are the different features of these malocclusions? All these things we have discussed in our earlier classes. Now we are going to discuss the treatment of these conditions. So, what is diagnosis and treatment planning? Basically, a diagnosis is the accumulation or assimilation of all the facts a person presents to us, whether through clinical or through by different diagnostic aids. So, we are going to retrieve, we are going to come to a conclusion what the problem of the patient is through different means of study of diagnostic aids or by clinical diagnosis. So, it doesn't matter whether you are studying medicine or dentistry, the concepts remains the same. So diagnosis is what we come to a conclusion what the patient is having based on the informations provided by the patient himself or from the facts or diagnostic aids we have collected. So what is the treatment plan? Treatment plan, just it is the outline of all the measures taken to provide the best treatment possible option available to the patient. We present the different methods of treatment options available for treatment of a particular condition. So these conditions should benefit the patient. So what are the different treatment options available to us for the benefit of the patient and to treat to the best of the health of the patient is called as treatment plan. Now we are going to see the different common malocclusions. We have different common malocclusions as we have discussed earlier. So we have what is called as intra-arch malocclusions that is present within either the maxillary or mandibular arch. Usually these intra-arch malocclusions are dental in nature, and we have inter-arch malocclusions, and again inter-arch malocclusions are three types: the sagittal, the vertical, and the transverse. In sagittal, we know the common classification, the class 1 angles classification, class 1 normal, and the class 2 are post normal, and class 3 the pre-normal. Likewise, in have vertical relations, we have a deep bite and open bite depending upon the overlap of the incisor teeth, and in transverse direction we have buccal cross bites and lingual cross bite. Likewise, we have what is called as intra-arch within the same arch. The spacings, crowdings, the inclination of the teeth, the displacement, abnormal appearance, rotations, and transpositions of all this. This may be either skeletal or dental or both. So it is a combination of the skeletal component or it may be due to a dental problems. We have all discussed this in our earlier chapter, the etiology of malocclusion and the classification of malocclusion. Likewise, in vertical relation, if you can see, there is a normal overlap of incisors here, and what happens in deep bite, the overlap increases and the amount of the vertical overlap is more, so that less amount of central incisor, lower central incisor is seen. So this gives rise to what is called as deep bite. It may be dental or skeletal. Likewise, if there is no overlap between the upper and lower incisors, it leads to what is called as open bite. It may be again dental or skeletal. Likewise, we have sagittal relations, normal sagittal relations, whereas the mesiobuccal cusp of The first molar occludes in the mesiobuccal groove of the lower. So what is class 2 in sagittal relations? Relatively when the maxilla is ahead. So that the distobuccal cusp occludes in the mesiobuccal groove of the lower. What is class 3 or prenormal? When relatively the mandibular molar is ahead. So that instead of molars of the maxillary arch, if it occludes with the premolars of the maxillary arch, you call it as prenormal occlusion. So the relatively the mandible is prognathic here. So another one is transverse small occlusion. Normally in transverse small occlusion, we have the vertical overlap of the upper buccal teeth over the lower teeth. When this relation is reversed, you call it as lingual crossbite. Or sometimes instead of not only buccal, if the lingual also overlaps the buccal of the lower, you call it as buccal crossbite. So, different treatment of malocclusions involves orthodontic therapy. Orthodontic therapy is nothing but application of forces which move the tooth or dentition. It also involves what is called as orthopedic forces, which is aimed at the correction of skeletal aberrant conditions, usually taken up during the growth phase. So, depending upon the age of the patient, the disproportion in size shape of the jaws can be corrected in sagittal, coronal, and transverse modes by growth modification, usually taken up during active phase of growth. Next comes camouflage of treatment. This is done when mild skeletal corrective orthodontics in adults. So here, though there is an indication of it's a borderline indication for surgery, we are not going to surgery. We are going to mask the skeletal component by changing the inclination of the upper and lower incisor teeth. This is called as camouflage treatment. And the last phase is called as surgical treatment or the orthognathic surgery, which is taken up when the entire growth is completed. When the entire active growth is completed, you are going to take this in adult patients. So the growth modification or growth modulation can also be brought about by myofunctional appliances or orthopedic appliances. And myofunctional appliances bring about the retrognathic mandible forward, whereas the orthopedic appliances bring the maxilla or they control the maxilla. These are all the things which we have discussed in our earlier chapters. So what are the different considerations before treatment planning? So as already we have discussed, first we should be able to identify the type of malocclusion and the etiological agent. What is the etiological agent? Is it genetic factor or due to any local factors, or it is due to the abnormal habit, or due to any other systematic condition which is causing this factor, this malocclusion we have to diagnose. Then how much complex is it? Whether it requires orthodontic or which requires both orthodontic and surgical procedures, and depending upon that we do what is called as triage. Depending upon the complexity of malocclusion, we do triage. The segregation or timing of this is usually done in emergency cases. So this triage is also followed in orthodontics. What are not in the bounds of an orthodontist will be referred to in higher centers. What all we can do at particular age and particular point of time, we will take up. This is called as triage. So before rushing to the orthodontic treatment, you have to see the normal systematic and dental health of the patient. Next comes evolution of malocclusion in all three dimensions, and age of the patient is very important, as we have seen whether we are going to do a growth modulation or camouflage or orthopedic treatment or orthognathic surgeries when the growth is completed. And the type of appliance and retention is very important aspect. Depending upon the type of malocclusion, the type of retention changes. So we are going to treat the common malocclusions. These type of malocclusions, these intra-arch malocclusions usually occurs in class 1 relationships. They are commonly occur in class 2 or class 3 conditions also. These are usually intra-arch malocclusions except bimax proclusion, which is inter-arch relationship. What are the malocclusions? They are generalized spacing, midline diastema, crowding, the rotation of the teeth, open bite, deep bite, cross bite, and bimaxillary protrusion, etc. And class 1 with crowding is the most common type of malocclusion found in India. We're going to discuss now. What is midline diastema? As the name indicates, diastema is the presence of the space or is the presence of pass through. Midline diastema refers to the presence of the space in the midline of the space or the midline of the upper maxillary arch. It is the most frequently encountered malocclusion and it seems to be very easy to treat but difficult to retain. So when we see this epidemiology of diastema, it is very common to see a spacing in the primary dentition. This is a must and all the primary dentition should have a common spacing. In mixed dentition also we can see the spacing between the central incisors. So 2 millimeters of space is common before the eruption of the canines. But once the permanent canines erupts, this midline diastema should close. If this midline diastema presents even after the eruption of canines, then we have to treat it by some orthodontic means or by non-orthodontic means. Usually, the blacks have more predisposition to the whites and it is more in males. So what are the different causes of diastema? One is transient malocclusions or temporary malocclusions, where we see during primary dentition stage the broadband phenomena which we have discussed. And of course, they are seen as a part of generalized spacing. We derive our dentition from father and the skeleton or the base on which these dentition rests from the mother. If there is mismatch between the size of the teeth and the size of the arch, if the size of the arch is more than the size of the teeth, or if the size of the teeth is less compared to the size of the arch, then we have generalized spacing. If there is generalized spacing, this leads to what is called as generalized spacing in the arch, and the diastema is a part of generalized spacing. So when arch length is excess, these generalized spacing may also result due to the abnormal shape of the teeth also. And sometimes some races and genetic predisposition will be there. And pathological, of course, abnormal frenal attachments and habits, abnormal habits, and of course midline pathology within the bone which is not visible due to the presence of any supernumerary cysts and tumors. All this may give rise to what is called as midline diastema. And the third one is physiological or like this patient go on clenching and deep bite, these faces open up. And iatrogenic, sometimes during the maxillary arch expansion, we will try to open the mid-palatal suture. When the mid-palatal suture is open, we have called as open in the central incisor area, we are going to cover diastema. It is a good sign. So this is transient malocclusion, broadband phenomena usually seen before the eruption of primary permanent canines. So this is how it looks before the eruption of permanent canines. This is because the erupting canine exerts its force on the roots of the lateral incisor. So as a result, the crowns gets diverged. When the crowns does diverge, there appears a space at the midline. So when the tooth starts erupting, the force is transmitted from the root area to the crown area. So the midline diastema closes when the permanent canine starts erupting down. So this is, can you see? When the force is at the root, the midline diastema develops. When the crown starts erupting and reaches here, now the force is transmitted towards one another and the space closes. This is a transient malocclusion seen in during the mixed dentition stage. So what are the other causes? Sometimes abnormal shape of the teeth which gives rise to microdontia. Example, peg laterals. Or sometimes the teeth itself may be without any deviation in the shape. There may be small in size. This also gives rise to generalized spacing. And pathological conditions like thick labial frenum sometimes prevent the approximation of the two central incisors. There opens up a space. And diastema due to congenitally missing teeth, sometimes or extracted teeth, sometimes a midline diastema opens up in the middle. Sometimes a pathological factors, a mesiodense or the supernumerary central incisor present in between the two permanent central incisors may give rise to a mesiodense. Sometimes abnormal habits like tongue thrusting and the periodontal weakened periodontal may also give rise to midline diastema. And as explained, the traumatic bite, the constant clenching of the upper and lower teeth, the hitting of the lower teeth against the upper teeth may sometimes lead to the midline diastema. So how do you diagnose it? The diagnosis is straightforward. We can see it in the patient's face itself whether he's having diastema or not. But we have to find out the etiological agent. So many etiological agents we have discussed. So the best part, the important part, or the important aspect of the treatment planning of midline diastema is to remove the etiology. Not only this, any malocclusion to treat before we have to remove the etiological agent. So all these factors we have to go have a thorough search to find out what is the cause of midline diastema. And there should be proper overjet to correct the midline diastema. And that as the teeth, like this midline diastema as well, as the teeth are retracted, the diastema closes. So there should be some space between the upper and lower teeth. If there is no proper overjet and lower teeth are touching the upper cannot go back and diastema remains like this. So there should be proper overjet between the upper and lower teeth before attempting to treat the midline diastema. And you test what is called as blanch test. You push the lip like this and push the lip upwards. You can see blanching at the frenal area. It becomes white, from red to white it becomes. When it becomes blanched, it indicates that labial frenum is the cause of midline diastema. And you have to check the incisive papilla. When you move or when you manipulate the lips along with the labial frenum, there is what is called as dancing of incisive papilla. Incisive papilla starts moving. So this is, you can clearly say that the midline diastema is the result of the presence of an this thick labial frenum. And radiographic examination, you can find a notch at the interdental alveolar bone, and positive blanching test or diagnostic features that the labial frenum is the cause of normalcy. Of course, you have to take an occlusal radiograph and other radiographs to rule out any pathology in the midline, such as cysts and tumors or any supernumerary teeth. And of course, you have to check for the presence of any habits. This is called as what is called as notching. Instead of clear-cut knife edge margins, you can see that notching and clear demarcation in the midline in the periapical radiograph. There is a notching of the border. This is an indication that that particular labial frenum is the cause of midline diastema. So how you are going to treat the midline diastema? So you can treat the midline diastema in primary dentition? No, because the spaces in the midline diastema are physiological and they should be there. No active treatment should be carried out during this stage to close the midline diastema, because the erupting permanent teeth are bigger in size. Unless there is some space for the permanent teeth to erupt, they will go into the crowding, what is going to call, we are going to discuss in our later discussion or later classes. So there should be some spaces in primary dentition and midline diastema should not be corrected. And coming to the midline diastema, we have discussed in mixed dentition what is called as transient malocclusion or ugly duckling stage. You have to remember that you should not treat the ugly duckling stage until the closure of the space by the eruption of the canines. Even after the eruption of the permanent canines, when the space remains, then only you can correct the midline diastema. But there are some indications where you can close the midline diastema in mixed dentitions. One, it is very anesthetic in appearance and it is having the psychological effect on the child patient. Then you can start closing the midline diastema. Sometimes the incisors are so much so widely separated that they may hinder the eruption of the permanent canines and lateral incisors. In such cases also, you can draw the two permanent central incisors close together and close the diastema. But remember, always you can postpone in normal and ordinary circumstances until the eruption of the permanent canine. So you can clearly see here the presence of midline diastema in a child patient of 78 years, and the same patient when noted at 10 years, the midline diastema is closed. So permanent dentition period. The midline diastema is very anesthetic and they have to be very much closed during the permanent dentition period. There involves three phases: heterotropic phase, corrective phase, and retentive phase. As the name indicates, heterotropic phase is the first phase. That means in heterotropic phase, you have to remove the etiology. Sometimes it can be done along with the corrective phase. So how you remove? If you find some abnormal habits, give an habit breaking appliance, either fixed or removable. If you find any midline pathologicals in your X-ray or diagnosis or clinical examination, remove them. They should be eliminated. And frenectomy. If you find that abnormal notching in the radiographs and positive blanch test, go for labial frenectomy before trying to attempt to close the central incisors. If sometimes during approximation itself, the labial frenum gets dissolved. Otherwise, before trying to attempt the closure of midline diastema, better you go for frenectomy and remove the thick, fleshy labial frenum. So now you can see that thick labial frenum causing the midline diastema. ZY plastic is done and sutures are placed. So next one is corrective. Corrective means how you are going to correct the midline diastema. Just by cutting the labial frenum, the midline diastema won't close. You have to apply some kind of force to make the teeth move together. This is called as corrective phase. It can be done with simple removable appliances when the midline diastema is 2 mm or less. But remember, always removable appliances leads to the closure of midline diastema by tipping of the teeth. By tipping means like this, crowns moves in one direction and root moves in another direction. So the best treatment or the best stability that can result is by moving the teeth bodily. This can be done with the help of fixed appliances to treating the midline diastema. And if more than 2 millimeters of space, tipping is not possible. You have to move bodily like this. The tipping is like this, closing midline diastema. If you tip more amount of space, can you see the triangle area here? The triangle area remains. This triangle area remains. Black triangles they're called. That is not what is called a suggested mode of treatment. So fixed appliances you can go acceptable. It is not an acceptable method. So how can you do this? So you can do with springs in the case of removable appliances. Sometimes you can incorporate elastics or springs, either open coil spring or closed coil spring made up of nitinol or springs woven in the stainless steel. All this can be used to close the midline diastema with the help of closed coil springs. So they are stretched between the two incisors. But remember, without a wire support, don't give elastics without any wire support. It may going to cause periodontal problems or loss of periodontal attachment. Can you see here spring in fixed appliances? It closes the space. This is an example of an elastic. This is an example of springs. Whereas in the removable appliances, can you see two finger springs that are trying to close the teeth together? So here the mesodens is removed. We have noticed that the midline diastema is to mesodens. It is removed and a fabrication of a split labial bow is done. A split labial bow moves this side teeth this side and right side to the left, left side to the right. So after 6 or 7 months, the spacure is closed. This is due to tongue thrust habit. So the patient is an adult patient. He was given a tongue thrust habit as an etiological agent. Here you can see both the etiological phase and corrective phase are carried out at same time. The corrective orthodontics was done with the help of an fixed appliance, and fixed tongue spikes were given to break the habit. And the post treatment, you can see the closure of spaces here. And this is a simple mechanism, again midline diastema closed with the help of simple buccal tubes. Close. So the other important aspect of midline diastema is the retention phase. It is a very critical aspect. So it is very easy to close just by giving the space, but you should see that it should not open up. If you want to see that it should not open up, you have to give some kind of permanent retention in adult patients. So you should see that according to Andrew 6 Qs of occlusion, we have seen that there should be no spaces left out. If there are spaces, again midline diastema opens up. So long-term retention should be planned, preferably with a fixed lingual bonded retainer, or sometimes any other surgical procedures like supracystal fibrotomy. If the central incisors are rotated, can also be done. So this is an example of a fixed retainer along with a Holly retainer. So if all the conditions are favorable and good occlusion, except the anterior incisor and spaces are less than 2 millimeters, you can consider, instead of orthodontic treatment, you consider composite fillings, you can consider the laminate. So this brings about the end of the diastema closure, and of course the treatment of diastema also. Next comes the spacing. Spacing is very similar. We have discussed about localized spacing in diastema. A generalized spacing is a overall picture of what is midline diastema is presented. So almost the etiological agents are same as that for what is discussed for our midline diastema. So there are two types of spacings in the arch. One is generalized spacing. So generalized spacing, usually it is the discrepancy, or it is the when the arch length is more and tooth material is less. This results in increased arch length, or more space is available for a fixed unit of teeth. So there may be spacing. If the reverse happens, if the tooth size is more than the arch length, it gives rise to crowding. Remember this. So when the relative conditions of macrodontia and microdontia will lead to generalized spacing conditions. Sometimes it may be associated with oligodontia or absence of certain teeth and hypodontia. All this leads to the spacing in the arch. So localized spacing, when the tooth morphology is abnormal, such as peg laterals, it is predisposed to spacings. Sometimes you may find one or two teeth missing. When the teeth are missing, then the adjacent teeth move into that space, opening up of the spaces. There may be rotation of the anterior teeth. They may be lead to spacing. Sometimes finger sucking and thumb sucking, they may open up the space in the anterior region only. Sometimes an abnormal tongue which cannot fit into the trough of the mandible can also give rise to the spacing. And the presence of unerupted supernumerary teeth, it adds up to the tooth material, and cystic lesions between the teeth can also cause as spacing in the arch. So you can see microdontia or small teeth giving rise to generalized spacing, and premature loss of the first molar in this arch has given rise to spacing in the dentition mesial to it. So diagnosis is same that of midline diastema. A thorough case history has to be taken, rule out the periodontal diseases, rule out the abnormal habits, and arch length tooth material disproportion should be analyzed by the patient's model analysis, and radiographic examination should search for any unerupted normal or supernumerary teeth and any existing pathological conditions of the tooth. So usually, as appropriate treatment plan in primary and mixed dentition is not done for generalized spacings, and removal of the etiology just for our coming to the permanent dentition, removal of etiology. In mixed dentition, you try to remove the habits. If the patient is having abnormal habits, try to remove them. and correction with active and removable appliances. And usually when generalized spacing is present, it is preferable to use fixed appliance because they bring about bodily movement and usually indicated in permanent dentition. As for midline diastema, just similar to the midline diastema, you can use the elastic springs and space closing loops in the arch. Sometimes, if you think that if you do bolt-ons analysis and you find excess, you do all the model analysis, still your upper and lower teeth are not matching, you can go for what is called as crowns and prostheses so that no space exists in the arch. So this brings about our first part of the treatment planning. Next part we will discuss it in the next class. Thanking you. Thanking all of you.